Now is your opportunity, because in the previous session, there was some provocation which was to the leaders. And I'm joined on this stage now with 3 leaders of our systems. But before I introduce them, I'm just going to say a few words. Now, I hope you'll agree that the sessions throughout the day have been illuminating, provocative, challenging, I suspect, to some of us. I think some of our speakers were absolutely outstanding in the way in which they presented the inequalities that we need to face into and really work hard to create a truly inclusive environment within which we can deliver health and social care to the communities that we serve. So we're going into a session now which is to look at the importance of innovation for integrating our care systems, and clearly we've had some examples in the last session and throughout the day. But I just want to say a few words, I guess reflecting so far, in terms of the challenge and the opportunity that we've got ahead of us. We've got the ability in the new system that's been created to rethink, to reimagine, to reset perhaps what we do and how we do it. And in particular, as we think of that, how we mobilize the talent in our organizations to really help us engage and listen to the communities that we serve. That whole piece around co-design, co-creation is critical to how we think about innovation in our integrated care systems. Co-design isn't easy. Co-design requires us to listen hard and also to seek out, to find out, and then to act, and to test what we're doing as we go. David, I think, challenged us all in terms of our bias and our history. And he also, I think, challenged us to engage with that, and own the inequalities that are clearly visible across our systems and services. Certainly in my background in education, we have huge education inequalities in our universities and in our schools. It's equally true, I suspect, in our health and social care systems. And David, I think, really helped us understand that in a very powerful way. So integrated care systems have been established to try and close some of these gaps. They've been set up to reduce health inequalities. And everyone in this room, I'm sure, is committed to being able to do that. The challenge question is, how do we do it? How quickly can we do it? And how will we know that we're being impactful and successful? So I'm joined by 3 colleagues who are going to help us navigate a way through this. Sue Harriman and Shane Devlin and Mary Hutton. Sue Harriman from BSW, Integrated Care System. Shane Devlin from BNSSG, and Mary Hutton from Gloucestershire. We're all trying to work together, we're all trying to learn from each other, and we're all doing things in slightly different ways. I suspect some of that will come out. So we've got inputs from each of them, 5 minutes each, and then we're going to go into some questions. So get ready, because Slido is going to be on air again, and I'll take questions from the floor, Slido. And if you're very, very quiet, which I cannot believe after watching you earlier, then I've got some questions up my sleeve as well. So without further ado, I'm going to try and make sure we have plenty of time for the questions. I'm going to invite Sue, and the question is, how research and innovation can support and add value to BSW, ISB, and Integrated Care System strategic priorities, including examples of current activities. So what a mouthful that is. Over to you.
Thank you very much, Steve. Sounds a bit like an exam question, doesn't it? So I thought I'd start by reminding myself why I decided to apply to become a Chief Executive of an Integrated Care Board. A nurse by background, the last 10 years I've worked in the community mental health, learning disability and autism sector as a provider chief exec. And I've seen the power of local communities. I've seen the fragmentation between services and organisations. And I've been frustrated by the lack of attention that is paid to all of those areas. The other reason is I had the privilege to be involved in the national vaccination programme before the vaccine was brought into use. And I worked directly with all the scientists involved in the production of it. I had complete blind faith that we would get there, but to see that innovation come to life was amazing. I also saw, when we started to deliver the programme, the stark inequalities that we had. Just by looking at the data, we could see that those that were able, those that were upwardly mobile, those that are able to access services easily, did so. So we were generating an enormous postcode lottery. All of those reasons made me realise I wanted to go into a place where I could effect change. And for me, being in the integrated care system and being the chief exec of the ICB was that space. Now I arrived, and I think we're 7 or 8 months in, and we're post-pandemic, we're dealing with the financial challenges, all of those things that you know very well. And in fact, there is every chance that we do what we've always done and miss the real point about effecting the change. So we have a legal duty to promote innovation. I wrote down the words. We have to create the capacity for adoption and spread. Our joint forward plan needs to recognise that, and our operational plans need to think about the NHS long-term plan and the transformation within it. There is every risk that we fill in those plans, we fill in those strategies, we tick the box, and then we move on and we get back to fighting the fires. We can't do that. I'm absolutely clear that the way we deliver health and care services as they currently are is not the way to do it into the future. We've heard that so much this morning. So really importantly for me, if we think about innovation and if we think about that through the lens of inequalities, we have to find a new way forward. And what the innovation allows us to do is to think about new ways of tackling old problems. It creates an evidence, and we're not very good when we affect change at measuring the evidence around it. So change doesn't stick because we never look at the outcomes that we've achieved. We don't set ourselves up to succeed or to succeed well, or indeed to fail well and to learn. I think we need to encourage the curiosity to think differently, to empower colleagues, and I fundamentally believe that change does happen as close to service delivery or within communities. The question earlier around ICBs being big and do they miss the point, we really will miss the point if we think that we affect the change just once centrally in the centre of the integrated care system. We have to empower locally. There's obviously benefits. We've got such talent out there that we need to liberate. We tend to bring external consultants in. Let's not do that. Let's use our own talent and use it very differently. So we've generated a strategy within BSW. It sits around 5 elements: culture, connections, community engagement, capacity capability, patient-person experience, and continuous improvement. And I think what we're trying to do is to realise we don't have all the answers and to work with anybody, actually, anybody and everybody who has an interest, and to build a community around that. So some of those examples, obviously, we're working with the Academic Health Science Network. We have our academy, which we're incredibly proud of, but we're working, starting relationships with the Dragon's Heart community, and actually we're linking through our integrated care partnership. And our ambition around innovation and in relation to inequalities in particular, we will be held to account by our integrated care partnership and by the broad membership within there. There are a number of examples within BSW. Some have been mentioned before. We are involved in the INHIT programme in relation to cardiovascular disease, in relation to the lipid optimization, but also, as I heard earlier from meeting somebody who I'd never met before who works in BSW in relation to blood pressure and blood pressure management. We are looking at creating, and I think Jane shared it earlier in her session, pulling the data and the information together in a way that makes sense for people to effect change and to use that in their everyday working practice, and a set of support tools around that so it's easy. Technology doesn't come easy to many people, and the use of information doesn't always come easy, and we are working to focus on that as well. And then we are creating, and I better get this right, the Research Engagement Network Development Programme, which is REND. And really that is bringing together the wide community, the wide voices, the different partners who have had either involved in research, interested in research, just want to learn and understand, but bringing those diverse voices together to help inform everything that we do. So that's me, Steve. I'll hand back to you.
Thanks very much, Sue. Now, I'm going to go to Shane next.
Yep. Thank you, Steve. So much like Sue, I joined, about 8 or 9 months ago now, originally from Northern Ireland, and I was chief executive of a large integrated system in Northern Ireland. When I came over, one of the things that struck me about innovation and change within our system is that we had an awful lot of stuff going on, okay? And stuff going on is the way I would describe it. And we had 191 projects going on in BNSSG. And what I really want us to try to do, and explain the process we're going to bring forward, is to try to refocus the whole organization and the whole of the system on 4 major improvement and innovation targets. And what that is creating is a system-wide group of 4, what we're calling them health and well-being improvement groups, but they're actually innovation groups. That's what they're there to do. The first one is about improving the lives of people in our community. The second one is about improving the lives of children. The third one is improving the lives of mental illness and autism. And the fourth one is improving the outcomes from our hospital as a result of improving efficiency and effectiveness in our hospitals. So rather than trying to do 101 things, we're saying from a system perspective, we will bring all the players together and refocus. Each of those innovation groups is jointly chaired by our partner chief executive and someone from within the ICB. And those innovation groups will then have people from a BI perspective, they'll have an HR perspective, they'll have, as Tash has agreed, AHSN input. And in fact, we stole Ellie from the AHSN to help us design this as well, which is really important. And what we're trying to do is pick a practical approach to how we drive innovation within BNSSG. Because my concern was, and it was brilliant to be, by the way, in the ecosystem working group just before here, my concern is that we've got this big ecosystem in BNSSG, and it's not hardwired together. We've got all these bits, and there's lots of really great stuff going on. But the bit over there doesn't know what the bit over there needs, and the bit over there doesn't know what that bit over there is doing. So it's about how you hardwire it together. So for us, we're creating 4 innovation groups that will hardwire both patients and clients as part of it, so the need, will our strategy people involved, our data people involved, but primarily, and the important thing is, run by our partners, not run by the ICB. And the strategy of our partners and their strategy based on the population is what drives those. So we've developed the outcomes framework that each of the 4 must drive towards, and ultimately then there will be 3 or 4, I believe, big transformation projects that will come, and therefore the bit in the ICB we've created is our transformation hub, where we're putting the skills to outreach into the 4 innovation hubs. So for us, and for me, it was about trying to bring all the good stuff, and of which there is loads in BNSSG, and I'm sure it's the same in Gloucester, and I'm sure it's the same in BSW, bring it into focus, so that, as I say, the term we're using is hardwire the bits together, so everyone understands what people's doing. Now, just the final part of that is that means we won't do everything for everyone. I think that's a really important part of innovation, because actually if we try to do everything for everyone, we probably end up not doing a lot for anyone. So what we're trying to do is bring it in. So there'll be some people who will say, well, I've got this great idea and this great need, and we're saying, well, you certainly do, but what we've got to focus on this year are these things. So that's, for us, is where we're going, Steve, is to try and really bring this into real strong focus run by partners. We've got, as you know, you're on our board. The board approved it about 3 months ago. We're in the process of bringing it together now, and we want the 4 innovation groups up and running by the beginning of April.
Brilliant, thank you. And approving is one thing, delivering is another.
You had the easy job.
Yeah. So, Mary, tell us about Gloucestershire.
Okay, so unlike my colleagues, I can't claim to be new in the system, so I've been around for a while, but nevertheless, the ICS is new. And we decided in September that we would really take the whole delivery of setting up as a strategy by the ICP really seriously. So we've got a lot of new partners from our community, from the voluntary sector involved. And we agreed that we would hold ourselves to account behind the ICP partnership, which is kind of brave because we didn't quite know what we would come up with together. And we now have established that strategy. And we set ourselves 3 main pillars. It's a bit, I suppose, simplifying what we're doing. So we've got a pillar that talks about what we want to achieve tomorrow. And we've all agreed together as leaders in the system that we're here now, we've got the resources now, but we need to invest now for changes that will impact the next 5, 10, 30 years and not just think about the reactive issues of today. We also are thinking about, in Pillar 3, about what we need to do about today and delivering services. And then we have a set of sub-pillars, which are transformation in the middle. And we've said localities and communities, inequalities, workforce, and transforming pathways and services, underpinned by, you'll be pleased to know, research and innovation, digital and resilient communities. So we've now set ourselves this plan, and our colleagues in the Integrated Care Partnership feel very strongly that they're holding us to account. So when we do our plan, as you do in the NHS, you never get asked about any of the other things you're doing around inequalities and research. You just get asked about your targets. But we are being asked by our colleagues about what we're doing on these other areas. So I think it will be really, really strong and fascinating. So just to mention research, I think research is undervalued and underreported. And we just launched a research festival starting yesterday in Gloucestershire to try and understand what's happening in research and to try and give it a different focus. And in that research festival, there are examples such as ophthalmology, really specific examples, but there are also lots of health and well-being issues, and there are panel discussions. People will have a chance to think through. And I've had a chance today to talk to some of the colleagues in the wider system who are involved in that work, and it's fascinating. And of course, we want to work with champions like the CRN, ARC West, the AHSN, and really think about how we can bring that together, and universities, of course. And we then have innovation. We've said innovation is everyone's business. It will be one of our underpinning strategies. If you're using QI methodology, which a lot of us are using, it means you have to question innovation in what you're doing. And we are just accepting that we won't deliver the future challenges around finance and workforce without innovation. And we just need to think about, and maybe that'll be some of your questions, about how do we adopt and how do we bring it forward. So I just want to give you 3 examples of the kind of things we're doing. And I hadn't looked at what you've got here before I picked my examples, but I could have picked quite a number of examples. I was pleased to see. We're working with K-Active, who are here today, and an AHSN scheme. We were an early adopter, and it's been really fascinating as we begin to think about diabetes in core 20 areas and how we can really work on this. And some of the results are amazing. 80% of people increased physical activity, and 71% of people maintained after the 12-week pilot scheme on K-Active in our system. That's fantastic, really, in terms of outcomes for that scheme. I was going to mention Latchied, but we've had Chen in this group talking about that, so I'm not going to talk about that again. And I just want to mention something that we've been doing for about 4 years. It's called cultural commissioning. And we talked about pain earlier on. So we were very fortunate to have Kathy Stannard, a consultant who was at NBT. I'm not sure if she's still at NBT, but she came into our system, picked one of our cohorts, first of all, were men who were locked into pain. So we had a group of 20 men who were going to the pain clinic, continuously getting more and more opioids to manage their condition. They were matched up with an artist and who did lots of work with them. They began to live alongside the pain and understand how to work with it. And that whole scheme has continued now, working with children, working with many other people. And in fact, the other day I was talking to one of our VCSE organisations who was telling me how fantastic the pain work was with the voluntary sector. And the outcome from that is a really heartwarming individual stories. Clinicians have learned that they don't have to continue doing the same thing, which is not delivering for them. But also, we've had massive savings in our prescribing as a result. So this is the kind of innovation we think about. So I would say for all of us, and my sort of challenge to myself now is that if I can't understand our research plan and how our research maps, if I can't understand our innovation myself, and we don't give it the right priority and publicity, then it won't be widely adopted. So I think we need to tell our success stories, and success breeds success. Thank you.
Brilliant, thank you. And the first thing I'd like to say is thank you very much for stepping into these leadership roles, because it was a bit weird to begin with in terms of what they were going to do and how are we going to bring them together and what are we going to focus on. And it's slowly becoming clearer. And I suspect that we're getting quite excited about the possibilities. We've still got to deliver them, but the possibilities and opportunities that are there. So let's just have a quick conversation before we go into opening up for questions from the floor. You've all mentioned this need to ensure that innovation is part of your thinking from the outset. You've all mentioned that there are some challenges around the adoption and spread. So when you're looking, I guess, into your organisations, what do you see as the main challenges in that adoption, spread, innovation into practice piece? And what tools are you using at the moment to try and, I guess, get round some of those challenges? Who wants to go first? I don't mind. Mary.
So I think, I'm not sure if everyone would agree with this, but I feel that we're in a kind of a frenetic state, really. And we haven't quite recovered from COVID, and there's a kind of a sense that what's the next reactive thing we're doing? So time has got to be set aside, and we're trying to ring fence some time across the whole system for people to work on this. And in primary care, for example, we call it our quality improvement projects, and we have got so many examples of people who are doing really innovative things, and they've really grasped inequalities, but you've got to give some time and you've got to give some focus.
Shane?
Yeah. Well, one problem we don't have are problems to solve. Okay, so we have plenty of opportunity of things we want to do. I think the challenge for us has been trying to bring it to a sensible size, focus on the right things, and try to get the bits of the system to work together. So if I can give an example, one of the things that struck me is the disconnect between our investment approach and an innovation approach. Our investment approach is very much focused on a business case. Normal business cases are a relationship between cost, benefit, and risk. And therefore, a business case tends to be focused on sort of might call technical change. If I buy this, it will do X. Whereas actually, what we're trying to do here is be a bit more exploratory. We don't know what the answer is yet, but we do know the challenge we face. I think that for us is quite a challenge because the normal mechanisms in health and social care are not set up to invest in unknowns. They're set up, or opportunities. They're set up to invest in purchasing. Yep. And I suppose, therefore, what we've got to try and do as leaders is to create both the physical space for people to come together to discuss that, but also some of the cover. And actually saying, well, actually, we will give cover. We will give permission that if we try something and it fails, please don't worry, we're not coming down to cut your legs off. What I would say is if you continually fail, then maybe we're doing the wrong thing. But there's something about creating that cover, because at the moment, it doesn't quite align. Yeah. We nearly only invest in the things we can prove are certain. And if you only did that, you'd never innovate. So there's something about getting that investment part up front and giving people the permission to try a few things. And that's what we're trying to do around the 4 areas for improvement, the 4 innovation groups, is people can try stuff. And then if it works, hopefully we can scale and spread within BNSSG, but actually we shouldn't, none of us should stop there at our own borders.
Yeah. Sue?
So I'm always a believer in when it gets really challenging, when it's frenetic, when there's a crisis, when we can't see a way forward, that is our greatest opportunity to make change happen. So I feel that weight of responsibility now. I guess building on the points that have been made, and reflecting back to the pandemic and how everything was different in the pandemic. Everything just came together, conversations were different, change happened. And actually in many places that didn't need a lot of infrastructure. Sometimes you need a bit of money in the right place, in the right way. But actually it was about giving away any power that anyone had to those that are enabled to come up with the right ideas, make the right decisions to effect the change that we need. So I think the risk appetite we have, the culture in which we work, and I think we've got a great opportunity, brand new organisations, brand new jobs, to kind of set that from the very beginning, and to kind of support colleagues to learn, to feel safe and to trust each other. So I think building on those points, that as well is really important.
Okay. I mean, one of the observations around the COVID stuff was that it was distributed leadership, it was empowerment, it was about innovation, and it was about risk sharing. And in many ways, the integrated care system is about risk sharing. NHS organisations, plus third sector, plus unitary authorities. And that's it's an interesting space, and we're all learning how to do it. But some of our system models that come down, so getting stuff from on high on Christmas Eve to work out your plan to then deliver in April is bonkers if you really want to innovate.
Mm-hmm.
So there are some things that I think collectively the integrated care boards need to start to understand and help the centre to understand. If you really want to innovate, if you really want to build a different sort of approach, then that air cover and that different way, different mindset is going to be critical.
Brilliant.
Otherwise, we'll just do what we've always done and try and sort it out through the money and chase the money, and it doesn't work.
And I think you raise a really interesting point, Steve, about risk. The Integrated Care Board is a collection of partners that are statutorily responsible for the outcome of the system.
Yep.
Okay? So it's not individual organisations looking at risk in their individual boundaries. It's actually now an opportunity to look across all partners to say, well, actually, if we do that over, or more importantly, actually, if we don't do that over there, the consequence will be over there. And by the way, as a collective board, so in our board, as you know, all the chief executives, all the partners are on that board, yourself, others. So it's not an organisational risk conversation anymore. It's actually a systems risk conversation. And that for us is going to be really hot, transformational in the thinking, which is, as much as I'm a legitimate standalone organisation, I've signed up to the consequence of system. And therefore, we've got to start looking. And one of the biggest risks I think we always ignore is the risk of doing nothing. And the risk of doing nothing over there could have a really detrimental impact over there. And for the first time ever, all the partners are on that board who are saying, well, then you better do that, because if you don't do that, I'm going to fall over. And it's bending the mind at the moment, let's be honest, around the board table. So for me, it's a great opportunity, but we've got to grab it. We really do.
Mary?
I think it's the relative size of investment. We started off a couple of years ago, a mile a day in primary schools. Our pump prime investment was £5,000. So this is what I mean about we're the leaders for now, but we also, together in our systems, need to think about what do we do now for the next 5, 10, 15 years, and that's innovation research come into that, and some of the amounts of money are very small compared to the very large amounts of money we spend on elective care, urgent care, so we have to get that prioritisation right, and I think it will be quite challenging to shape the funding to match the kind of priorities we're setting out.
Okay. So the culture of innovation in the system, in a system that's just it's early maturity, it's still learning how to do this, but you need that innovation to be happening in different places. So I guess the question for me is how do we together instill that sense of community around innovation and that risk and the air cover, I guess, that we all need in order to be able to do it? Because some of this isn't going to work. Some of it's going to fail, and you want it to fail preferably fast and not in a catastrophic way. So how do you get people to think that way?
So, I think there's something in my mind thinking about the reality of where we are now, where there's pockets of this stuff that happens everywhere all the time, and the reality is that half of us don't know what's going on. I certainly don't know what's going on. And I think there is also the other reality that we've got. We're really early in the days of working as a system, and we've got organisational boundaries. So, what's good for one may be different for someone else. We just need to say this stuff out loud to be able to recognise that our job is to work together, to share the collective innovation, the thoughts, and we don't do that well. I think. If I have a very high risk appetite, I think I've learned over the years, I would really like to step out of the role that I have in the ICB and sit in a space of enabling, listening more actively to others and being guided by others. So rather than leading or indeed listening to above, I need to be able to be brave enough to speak truth to power. I'd expect anyone to feel safe and able to do that at all times, and for us to listen to that. So to become more of a supporter and a facilitator, Obviously, there's something about the amount of time we spend talking about it, creating the social movement around it, all of that sort of stuff. And I think, the obvious thing, I mentioned crisis, or out of a good crisis comes a massive opportunity. I think it's about demonstrating that innovation isn't something for next year, isn't something that academics do. Forgive me, all the academics in the room, I'm sure you do. It's something we do every single day, and it changes what we do. It makes us more efficient, more effective, makes us more inclusive. So if we can create the narrative that demonstrates how it helps now, it will help us move forward. Otherwise, we'll get stuck in balancing the books and delivering the targets, which will be a real missed opportunity.
And we've heard all the way through the day that this is a collaborative sport. This can only happen not just if the academics do it and the researchers do it, but actually we're working with communities, we're co-designing, we're listening hard, and we're influencing policymakers as a result of that, if we can, who may be still set in a slightly different place. No offence to policymakers, but sometimes they're not quite on the same page that the rest of us are on, and we sometimes have to nudge them a bit to do that. So, Mary, I'm going to go to you now, just in terms of how do you think we can influence those policymakers? Because if we are at now the front line, if we're where decisions are being made, how do we make sure that we don't get policy coming down that doesn't quite align with what we're saying? How easy is it to speak back up? And I say that because the integrated care system and our boards have different reporting lines. So the unitary authorities have a very different set of reporting lines to the NHS organisations and to third sector that we're trying to mobilise and get involved in this team effort, team sport.
I think there's a bit of an onus on us now because we're not starting from scratch. We've been at this for a number of years, and we have quite a lot of innovation that has been tried and tested. So I think we need to take some of those examples and map them out and evaluate them and explain the evaluation. And I've been looking at this myself. I came across an example on ophthalmology in our own system about a couple of months ago and thought, wow, why have we never talked about that before? I just don't understand. I've been talking about it ever since I found out. So I think we need to think together about some of the examples. We've now got quite a lot of examples around inequalities where people are understanding that we have sort of started to we've been focusing for years on the people who come forward, but we have the evidence of the people who don't come forward. So we need to do some of that, and I think we could together start pulling together some of that work. And when you begin to show the evidence base and to explain, it's one of the solutions to our financial position, our workforce position. And we found this with workforce, looking at people who are doing youth work, people who are doing personal training, all of that. There's lots of workforce in our system that can be brought into our planning. So we need to think and explain it more clearly. I feel that's one of our emphasis, one of the areas we're going to emphasise over the next year. How do we document and explain so we can give worked examples? And all of us could do that together, I think. And I want other people's innovation that's worked out, ready to deliver, and just can land and go.
Yeah, well, we need to work as a network, don't we?
Yes, exactly.
There'll be somewhere,
yes, exactly.
Someone is slightly ahead of somewhere else.
Yes, exactly.
So let's learn how to collaborate and share and nick ideas if they're good ideas.
Yes.
Why not? Let's make sure we do that.
Could I add, Steve, to Mary's point? I mean, the question you raise is a valid question and put in a provocative way, which is, do we push back and against policy? Most policy is pushing us in relatively the same direction. Okay, so I think we have to be clear that what NHSE want to do, what the Department of Health and Social Care want to do, has been embedded in legislation and is the basis of what we're trying. So I think most of it is pointing roughly in the same direction. Yeah. But I think what was interesting this year when the five-year joint forward plan guidance was produced, very early, one of the early paragraphs, been a big debate at our ICP about this, when the early paragraph said, and the purpose of this plan is for the ICB and its trust partners to deliver a five-year forward plan. And as a system, we drew a pen through that, and we said, no, it's for the ICB and its partners, which includes voluntary community, which includes local authorities, which includes academia, all the kinds of things we have to do. No one pushed back and said, no, you mustn't do that. So I think we have credence to this great oracle at the top that's sending down policy and we must obey. The reality is we've been establishing legislation to do this, and our job is to have broad shoulders and to say, actually, we're going to work with our communities, we're going to work with our providers, and we're going to do what's right for our system, and in this case, a collection of systems. Because I think we give too much credence to this idea that there's some big controller who's got all the answers, and I would suggest there isn't.
I completely agree. So be courageous, be bold,
Yeah.
and take the tiller, I guess,
Yes, absolutely.
and work out. Brilliant. Please join me, Sue and Shane and Mary.